partnerships, design thinking, collective impact, translational science to policy. I could go on and on and on. And I'm really excited to have Terry joining us today. He'll be followed by my friend and colleague, Dr. Stephenie Lemon, who's the chief of the Division of Preventive and Behavioral Medicine at University of Massachusetts Chan School of Medicine, where she also serves as director of the Prevention Research Center and director of community engagement for the UMass Center for Clinical and Translational Science. Her research focuses on building public health sector, community member, and lay health worker capacity to implement evidence-based programs and practices and policies, systems and environmental interventions related to physical activity, obesity, and chronic disease management, with an emphasis on low-income urban areas. And I've had the pleasure of co-leading the Physical Activity Policy Research and Evaluation Network with her for the past 4.5 years. And finally, Dr. Nico Pronk is the president of HealthPartners Institute and chief science officer at HealthPartners. He holds an academic appointment as an affiliate full professor of health policy and management at the University of Minnesota School of Public Health. His work focused on connecting scientific evidence of effectiveness with practical applications of programs and practices, policies, and systems to improve population health and well-being. He serves on numerous committees and boards. He was confirmed by the White House as co-chair of the U.S. Secretary of Health and Human Services Advisory Committee on National Health Promotion and Disease Prevention Objectives for 2030, and he's also chair of the Roundtable on Obesity Solutions at the National Academies, as we've heard about throughout this meeting. And I had the honor of working with Nico on both the IOM report on evaluating progress in obesity prevention, as well as on the Community Preventive Services Task Force. So I'm delighted to turn it over to Terry. After their presentations, just like the other sessions, we'll have about a 25-minute period for Q&A. So feel free to enter any questions that you have as the presenters are going along, and we'll have a moderated Q&A after the panel is done. So Terry, I'll turn it over to you.
Thank you so much, Jamie, and thank you to all the organizers, working group members, for inviting me to be part of this incredible conversation. This workshop feels so timely. I actually co-founded INCORE back in 2009 while I was still at the NIH. And over the past decade plus, we made a lot of progress, but at the same time, it feels like we're in a little bit of a bottleneck, not necessarily seeing all of the results that we had hoped to see, a decade ago when we set sail on this journey to tackle childhood obesity and obesity in general. So I've spent the last few years, really trying to take stock and think a little bit more deeply about how do we actually move forward? Where do we go from here? And I was so thrilled to hear some of the new work that's coming out from our colleagues through the presentations today. And also some of the speakers gave like a really nice overview of what we've learned to date in certain areas. So for today's talk, since we're kind of at the end of the two-day workshop, I thought I would maybe zoom out a bit and offer just some food for thought, bigger picture food for thought, and in the hopes that this will foster maybe some more granular discussion about how we can actually design our intervention programs, strategies in a better way, in a different way, as we move into kind of the next generation arena in tackling this persistent and what one might call a wicked problem of childhood obesity. Next slide, please. I don't have any conflict of interest to disclose. Next slide. Next slide, please. So I would like to first share with you some of my recent thoughts on where some of the critical implementation gaps are for obesity and obesity-related interventions. And I'll group them broadly speaking into 3 buckets. The first bucket has to do with the implementation context. The second bucket has to do with the intervention components, targets, and sequencing. And then the third bucket, which we'll go into in a minute, has to do with delivery strategies. So in the bucket of implementation context, one of the things that has been lurking around, in the background this whole time, but I don't think that we, as public health interventionists, have always addressed head on, is this a mismatch between the intervention that we're trying to implement and the level of readiness part of the community in which we're trying to deliver the intervention. And, many other speakers today have talked about how context is so important, and the same intervention may or may not work in different contexts or might work differently across different contexts. And community readiness is really a facet of that context. And, I think there's abundant literature, showing the role that community readiness plays in a variety of public health interventions and outcomes. But in the context of obesity, this has not been as evident in the way that we design and deliver obesity interventions. So we have done some work, in prior years, my team that is, in trying to actually shift the community level of readiness as a priori, as a way to almost prime the community to be in a better position to receive behavior or lifestyle interventions. And we have shown that, it is possible to actually make that shift. And we think that by actually doing that pre-intervention in addressing community readiness, we may have a better chance at actually delivering evidence-based interventions more effectively. The second bullet under this bucket is really about the built and the social environment. And earlier we heard a number of talks on this kind of broad set of issues already. But I guess one of the things that I want to really highlight is it's very rare that we will actually see an intervention that think about or that explicitly address the intersection of the built in the social environment. And I think that's hugely critical. And so even as we move upstream to thinking about environment level interventions, oftentimes we're still working in silos, whether it's, dealing with a feature of the built environment, or we're thinking, about specific, social contextual issues, but not really thinking about the interaction of the two. So this is something that we're currently actually working on in New York City, where we've sort of dealt with the built environment from a park perspective, but realizing that park transformation alone, it may be essential, but not adequate in leading to improvements in physical activity or other health outcomes that we might desire. And so we're trying now to actually work on the social environment and while leveraging the transformations that have already been done in the built environment. So I think this is an area that deserves really a lot more research, and we need to better understand how to actually intervene in that interstitial space. The third bullet within this bucket has to do with a lack of attention to cultural nuances. Deborah Selble earlier talked about how assumptions that we have in the US about certain exposure outcome relationships may not translate, in other countries, in other cultures. But it's also true that I think increasingly we need to think about culture from a transnational context. And having worked with Chinese Americans in New York, for example, we've learned, much to my surprise, actually, that many immigrant Chinese parents send their children, their newborn kids, back to mainland China to be cared for by their grandparents. And it's not only until the children are school age that they get sent back to the US to attend school, right? And so this then calls into question, okay, if you were to design in behavioral intervention, how do you tackle caretakers that actually exist in two different contexts? So these cultural nuances from both a cross-cultural and transnational perspective, I think are increasingly important, as we particularly think about health disparities. The second bucket has to do with intervention components, targets, and sequencing. So one of the things that we often fail to remember is that when it comes to lifestyle interventions, there are a lot of different behaviors we're trying to target or having to target simultaneously, but people actually have different stages of change for different behaviors. And our interventions are not calibrated in such precise ways yet, but need to be. Secondly, we also often overlook issues related to participants' mental health, cognitive load, executive functioning. And so we're delivering interventions to end users who may not actually be in a position to optimally digest, process, and benefit from the lifestyle intervention. And so do we need to actually think about different intervention targets, that apart from obesity first, before we can actually address obesity, right? So, and so this actually leads into the third bullet, which is really about the knowledge gap that still exists on how to optimally sequence different intervention components. So if we agree that we need to address mental health first before we can actually deliver, some kind of behavior modification intervention, then we're talking about different intervention components or intervention targets, sequenced in a particular way. So I think we just need to become more nuanced and more strategic and more clever in how we think about all these different issues. Next slide, please. The third bucket has to do with delivery strategies. So really quickly, whether it's push versus pull strategies, or can it be both? We as public health interventionists, are more accustomed to push strategies, but often consumers are, respond better to pull strategies. One idea to be tested, where we could combine both, is to have an opt-out approach, which obviously doesn't work in every context, but it could work in some contexts to maximize reach, but still incorporate personal customization options, in terms of the intervention content. So we're leveraging both the push and pull aspects. Obviously, post-COVID, there's a lot of discussion in the literature around in-person versus virtual delivery. I think the jury's still out. What is the most optimal mix and for whom and in what context? And then intervention packaging and formats. We have issues related to dosage, delivery channel, and also a whole set of different incentives and disincentives that we still have to work through in terms of what works best and for whom. Next slide. So I want to also introduce this idea of being more action-oriented. So moving from kind of problem-centered public health to being more solution-oriented paradigm. And one way to do that is to really leverage the integration of both systems thinking, which I know that has been introduced earlier in this workshop, and design thinking. So the literature has talked about systems thinking and design thinking mostly separately, but I would like to propose a model where these two can actually be integrated in service of improving the implementation of obesity interventions. Next slide. So, our team has been doing a lot of this work over the past decade and experimenting with the use of system science strategies to improve community engagement, really taking advantage of system dynamics modeling in particular to help local stakeholders identify and prioritize and pivot their strategies, as time goes on. At the same time, I have learned over the last decade of working with designers and architects that there's just such a different way of thinking about solutions, how to come up with innovative strategies to kind of break free of whatever bottleneck that we're experiencing. So this new framework that we just published helps to illustrate how the two sides can actually come together to help fill some of the major gaps in implementation science. And very importantly, how to actually think about strategies that would sustain and scale public health innovation from the outset. So next slide, please. So, and one of the things that we also need to do that I want to just, do a plug here for is really thinking more entrepreneurially. And design thinking is really part and parcel to the innovation process in entrepreneurship. I think that we need to tap into the talents and resources beyond the traditional public health sector. We're doing this at CUNY through the creation of this new platform called Firefly Innovations, and working with startups to try to tackle some of these persistent challenges. So I welcome, folks reaching out to us and explore opportunities to collaborate. I know I'm over time, so I will stop here and just leave room for others and as well as the questions later. Thank you.
Thanks so much, Terry. Really appreciate it. We'll come back to questions, but let's quickly turn over to Stephenie. Thank you.
Hi, everybody. Welcome, and thank you so much for having me. It's a privilege to be here today. I'm going to be talking a bit about obesity-related policy systems and environmental implementation science. How do we build a field? Next slide. I have no conflicts of interest to disclose. I'll briefly mention that the work that I'm going to be presented has been funded by the CDC, and it's been informed by participation in NCI's Speeding Research Tested Interventions program. Next slide. Next slide. The purpose of my talk today is to catalyze our thinking about how to advance implementation science for obesity-related policy systems and environmental interventions. I'm also going to illustrate some of the concepts that I'd like us to be thinking about through some of my own work that has focused on the built environment and physical activity. Next slide. We've talked a bit about implementation science throughout this workshop, but I'm going to spend 2 minutes just doing some level setting to make sure we're all talking about the same thing. One definition of implementation science that I like is that it's the study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine care in order to improve population health. Related to this, implementation research really focuses on the uses of specific strategies to adopt and integrate evidence-based health interventions. So 2 key things to take away from this is that implementation science makes an assumption that there is an evidence base to implement. It also makes an assumption that implementation doesn't occur automatically and that we need to develop and test strategies by which to put evidence-based interventions into practice. Next slide. And this just further illustrates this. Effectiveness research and implementation research sometimes get used interchangeably. They are certainly related, but also distinct. While effectiveness research really focuses on what we know, what we're thinking about with implementation science is how to do it. So the question of how do we put things into practice is key when we're trying to think about implementation science. There's been a huge body of research around implementation science as a field that's come out, in the last decade or so. A lot of it has focused originally on healthcare, the healthcare setting, healthcare context, healthcare delivery. It's also been applied to community context and other settings. It has much more rarely been applied to policy systems and environmental changes, and that's where I'd really like us to start thinking. Next slide. So when we think about PSC implementation science, we can start on the left and think about first policy making. And so policy-focused dissemination research really focuses on how do we enact policies that are aligned with best practice? How do we get the word out? How do we get decision makers to adopt them, et cetera? Another way to think about policy and implementation science is policy as a strategy. The goal here is to use policy as an implementation strategy to put an evidence-based intervention into practice. While the first two are really important, I'm going to be focusing on the third, which is what I call PSC implementation. And the goal here is to identify strategies that maximize the implementation of an evidence-based policy systems and environmental intervention. So in this context, the PSC is the intervention that is evidence-based that we're trying to put into practice. Next slide. Before I go into my presentation, I want to just think about a few methodological things that I'm going to touch on. Implementation science as a field has several core elements, and I've listed 6 of them here. The first is we've heard a lot about over the last 2 days about engaging partners or other interest holders. Some of the PSC-related questions that we need to think about here are how do we do this across multiple sectors? These systems-level interventions are complex. They're multi-component. They require a lot of implementers to make things happen. How do we do this in a way that continues to center community voices while also influencing decision makers with intention? And then what are the best scalable practice for this? There's also a large body of evidence out there on our, process more than evidence on frameworks, models, or theories related to implementation science. The questions we need to ask ourselves are how applicable are these to policy systems and environmental interventions? Not that we need, new theories for the sake of having new theories, but a really careful consideration of what's available, what works and what doesn't is essential to move this field forward. Number 3 is probably an obvious one. We need implementation science is usually designed to test an implementation strategy. We need careful consideration based on what's already available in the literature around promising strategies to think about what applies to the PSC context. And also think about what new or innovative strategies haven't been thought before that we need to be testing. Number 4, we've also heard a lot about this week, taking local context into consideration and allowing for adaptation. The questions we need to think about, are how do we do this in a way that is potentially scalable? How do we consider local context up front while also thinking about generalizability and potential for scalability? And how do we develop implementation strategies across multiple sectors and levels that can be scaled? Number 5 is around study design. What are the most promising study designs to accommodate the really complex messiness of PSC implementation? What about hybrid designs where the primary goal may not be implementation and implementation is a secondary outcome? And then lastly, what are the correct implementation outcomes? What are the tools that we need to be developed? What are the measurement tools? And how do we handle really short grant timelines when it also often takes a very long time to put a policy systems or environmental intervention into practice? Next slide. So with these key questions in mind, I'm going to present just a quick sampling of some of my own research. All of this research is still in process. I'm not going to be sharing outcomes. I'm really just going to be sharing thought processes related to how to think about this as an implementation science study. So I'm focusing specifically on the built environment. The community guide, as Dr. Salvo talked about before, recommends built environment changes to influence obesity via physical activity. The guideline is actually for physical activity. And this community guide recommendation thinks about 2 key pieces of core of evidence-based intervention. The first is pedestrian and bicycle transportation systems interventions, and the second is land use and environmental design interventions. So in my research, this is the evidence base that we're trying to implement. Next slide. The relationship between environment, policy, and systems in this context is as follows. Implementing the environmental change is often the end goal. We want environments that support physical activity, that support, related co-benefits and also mitigate some of the unintended consequences. And there are a lot of different ways that a healthy community design can look, and that's our end game. But that doesn't happen by itself. Implementing these environmental changes often falls to, relies on plans and policies to put them into practice. However, this doesn't happen on its own. We have to think about how do we influence the systems responsible for implementation, as well as those that influence implementation. Next slide. And so the key underpinning of this is that the policy process thinks about implementation sort of in a way that if you put something on the books, it happens. However, we know that that's not true. And so where implementation science can come in is to think about what are the strategies to put a policy into place in the way as intended after it's been adopted. Next slide. And so this is kind of a complex slide that actually Jamie and I have been working on together for some time. Basically, this illustrates in a little bit more detail how we're operationalizing what we mean by PSC in this context. We can focus a little bit more on the S in the middle because this is the black box. This is what we've had to think about. How do we actually influence decision-making? And what we've essentially come up with in our specific context, there's sort of two systems that we need to think about. Our quote inside system, which are the implementers, the people in local government who have responsibility for these decisions. And then we have sort of an outside plus system, which are our influencers. This is the community at large, the people who can influence decision-making. It may be coalitions, it may be, different groups, et cetera, differs by community, but in general, at the local level, this is where we need to be thinking about where we implement and how we address our strategies. Next slide. And so I'm going to just very briefly, because I'm running out of time, talk about our research goal, which is to develop and test an implementation strategy that supports equitable implementation of built environment changes. Next slide. And so our work is being conducted in Worcester, Mass, which is the second largest city in New England. It's a very diverse city that has extreme population growth over the last couple of decades. However, we're in the middle of a massive housing crisis, as well as, some infrastructure issues. However, we're relying on, collaborating with a really invested group of multi-sector stakeholders and taking advantage of several things that have happened in our community related to the built environment, including complete streets policies and Vision Zero initiatives, et cetera. Next slide. And so we've essentially are in the process of testing an implementation strategy that we call Neighborhood Connect. We've piloted this and it's going into the field, but it's not quite there yet. But basically what we're trying to do is develop a strategy that influences how decisions are made in our community around the built environment. The first focused on the inside system in our local context relies on the local division of public health because they're the right person in our community. That might not be true in other places. And then our outside system involves working with a coalition and an advocacy group to mobilize community members in neighborhoods. And so, we're testing a sort of training and technical assistance model that's going to help prepare influencing the decision-making process, both from the inside and from the outside. Next slide. I'm going to skip over this slide. Next one. And so basically, when I come back to the methodological considerations, we're trying to think these things through from the very beginning and how we design our work. The first question around how do we engage partners and other interest holders across this really complex multi-sector decision-making process that involves, transportation, public works, et cetera. We do have a community advisory board that's influencing everything that we do. We have 3 delivery partners, and we also have an external group that's helping to help us think about how to do this in a way that's potentially generalizable. We landed on a theory that was not perfect. It didn't work perfectly. We had to adapt it, but we're using the interactive systems framework. I already talked about our implementation strategy. Our consideration of local context has been taken into in the development of what we're doing, but we're also thinking about how we do this in a way that is also generalizable. And then, the study guide and the implementation outcomes questions were really hard for us. And so we settled on a stepped wedge design, and the implementation outcomes piece we had to do from scratch because there's just nothing in the available literature that could guide us. Next slide. And so this is my final slide. And basically why I'm illustrating my work today is really to highlight a few things that I think we can take into the next session that is going to be held in the fall around where the methods base needs to go. And so as we pursue the next generation of obesity-related PSC intervention research, we need to consider things like further defining and operationalizing our systems, including who the multi-sector interest holders are, who are the implementers, and also who are the influencers, and think about how we develop strategies that reach those groups. We need to prioritize implementation even when we're talking about building new effectiveness research. There's certainly a need for new effectiveness research, but we want to be thinking about implementation and hybrid designs from the get-go so that we're learning as we go and not sequentially. We need to think about what is and isn't applicable from the current field of implementation science, and there may be a need to develop new methods, new measures, and new frameworks. And then we also need to think about additional methodological advances that we need to integrate into this type of research in order to put these policy systems and environmental interventions into practice. And while high-level thought and guidance is necessary, this likely is going to have to happen at a really nuanced level when we think about the different systems. We probably need to think about them as subsystems as we develop these questions and these methods. And I will end there.
Thanks so much, Stephenie. That was fantastic as well. I'm going to turn it over to Nico, and then we will wrap up afterwards with a moderated Q&A. So Nico, if you could turn on your camera, that would be great.
Thank you, Jamie. Can you see me? Okay. And thanks for inviting me to be with you all today. So next slide. I have no disclosures. Just to get started, I have really 3 areas of focus for my discussion today. One is to ensure that we start really focusing in on an upstream perspective, in particular, the roles of culture, politics, policy, and environmental circumstances. But also not to forget that we need comprehensive options for both prevention and treatment. And then close out with some comments on disseminating the knowledge that we know about what we know works and implementation of solutions using pragmatic frameworks focused on the practical setting. Next slide, please. So just to begin, this is a slide that you probably have already seen during the course of the conference. It's the Roundtable on Obesity Solution Systems map that was created as part of the work by all its members. It includes prevention and treatment, was co-created using a group model building approach, and was also prioritized by the members to get to that point of where are we going to focus, because you can't do everything that sort of shows up in the map. And so we ended up focusing in on structural racism, biased social norms, and health communications, which I don't think that the work of the roundtable would have gone in that direction would we not have taken this systems kinds of thinking approach. And it really reiterates that message that really, at the end of the day, all behavior by people, organizations, economies, countries, is really affected by the context in which it occurs. And so we need to probably start thinking more in circles rather than straight lines. Next slide, please. So the upstream perspective, first of all, there is great heterogeneity of obesity according to regional cultures across the United States. And that heterogeneity shows up and influences the drive, the way that politics show up in the local settings. Civic engagement is closely related to that. And that really establishes this linkage to policy development. And at the end of the day, policy development influences heavily the social, the physical, and the economic environments. And so we go to the next slide, just to show that. We know that if you look on the right side of this slide, the heterogeneity of obesity at the state level across the country has been seen for quite some time now, using these maps from the Centers for Disease Control and Prevention. On the left-hand side, we've basically taken obesity prevalence at the county level disaggregated it, and reaggregated it according to the American nations, the 13 American nations that are defined by different unique cultures. And you can see here that heterogeneity certainly shows up. You can see also across the board some hotspots here and there, but there is a clear sort of shift, if you will, in the picture from the right to the left that really is organized around the influence of culture on a health outcome such as obesity. And this picture is not alone. This is the one related to obesity, but it certainly is similar to pictures or patterns that come up when we do these graphs for gender wage gaps, for social vulnerability index, physical inactivity, life expectancy, chronic conditions, sleep insufficiency, or even firearm violence. Next slide, please. So the link then of those cultures to the political context is informed by results from a project that we partnered on with the Healthy Democracy, Healthy People initiative, where we made a comparison of 12 public health indicators and voter turnout and linked it to the restrictiveness of voting access in each state. What you see here is that basically states with more inclusive voting policies and greater levels of civic participation are healthier at the population level, which means on the flip side, states with exclusionary voting laws, states that make it more difficult to vote, have lower rates of voter participation and worse public health outcomes. So there's a strong linkage there between those two. Next slide, please. This then influences the link between politics and policy development. Key factors in policy for obesity certainly include the health outcomes, the interest in economic impact and sustainability indicators, and scalability. On the health outcomes side, we really do need to know what is the effectiveness of the solutions or the interventions that are being implemented. In other words, we need to know what's the effect size that we can sort of work around when we do our planning. On the scalability side, is it plausible to reach the audiences that we identify? And on the economic impact and sustainability side, there needs to be a clear cost per unit of intervention in order to cost things out. And that also includes the scope of services that need to be costed. So basically, more data is still needed on this prevention and treatment outcome side, on the health outcome side, including in particular data on the anti-obesity medications that have shown up on the market. The scope of services needs to be clearly defined, particularly when we think about comprehensive solutions and what does that really mean, a comprehensive solution. And then on the scalability side, anti-obesity medications are very high in terms of its potential scalability. So what can we do there to connect those with lifestyle interventions as an example? But really, at the end of the day, public policy then needs to align with implementation efforts and practice realities. What does this look like at the local level, where the rubber meets the road, so to speak? So policy in service of practice is an important perspective. Next slide, please. And that gets us then to the policy influence on social, physical, and economic environments. Here, just like to highlight that policy certainly has a strong influence. And that means that we do need to make sure we have a prevention focus, because incidence reduction is critical for long-term impact. But we also cannot forget about the need for treatment of obesity. And then certainly equitable access. The disparities need to be addressed and eliminated. And part of this relates to this need to address stigma and bias across communities, as well as in the care delivery setting. So access to resources, access to solutions, access to investments, and access to power really become important aspects to affect positively these different environments. Next slide, please. So on the second section, on the comprehensive options for prevention and treatment, what does a comprehensive solution really look like at the end of the day? Well, across the board, we certainly would need community programs that would address particularly the prevention side, across different settings, schools, workplaces, parks. We need to have access to digital health programs. Commercial weight loss programs are good options for people, but certainly lifestyle coaching and nutrition counseling. But then these multi-sectoral collaborations are becoming more and more important, where there is a linkage or a bridging of the gap between different settings, such as the workplace to the clinic, or clinical referrals into community programs. And where is the feedback for those services? How do we make sure that those feedback loops are being closed? The way we talk about obesity in general, using people-first language would be a good first step, but certainly not the only one. And then on the treatment side in particular, the access to obesity medicine clinics, anti-obesity medications, and bariatric surgery options. Certainly this entire list starts to get at this idea of comprehensive solutions. Next slide, please. And that means that we also need to pay attention to closing gaps in care. Comprehensive care teams that reach beyond the clinic walls are needed, but in addition to that, education of the health workforce itself. Clinician knowledge about comprehensive obesity solutions is lacking, which is not surprising, given the amount of issues and concerns that have to be addressed in the clinical setting. And this will not be, this solution will not show up until there is a clinical decision support solution that can really help a primary care physician get through all of these issues and still address the chief concern in the clinical setting. But how to address stigma and bias, how to address discrimination, both from the patient to the care team side, as well as the care team to the patient side. Equitable insurance coverage, safety and adverse events issues, the referrals to those community resources and making those available and accessible. And then finally, cost effectiveness data and social support resources. Next slide, please. So as we're getting towards the end here, I do want to make sure to sort of support what's been said before with an approach to dissemination and implementation. And much along the lines of what Stephenie was saying earlier, we do need, I think, a framework approach that makes sense. Now, the best framework in my mind is the one that's being used, because there are so many, and which one would you pick? So I think it has a lot to do with knowing your local context and finding the right framework to work from. I'm giving here an example of a framework that connects design of programs to implementation of programs and feeds back the learning that takes care, that happens in that process. So if you hit the next slide button, and here we see again, we need to know at a minimum, what's the size of the effect, what are the scope of services, can this program be scalable, and can it be sustainable over time? Next slide, next click, please. And again. And that would allow us to measure how deeply we can penetrate into an intended audience, whether or not the program was implemented according to plan, how many people are actually participating and using the program, and does it work? What's the effectiveness of it? And then click again, please. Feed that information back to the design phase and iteratively improve and continue to close that loop time and time again. This is the kind of approach that I think brings together a lot of the information we've heard about throughout the course of the last couple of days here. But it's simple enough to be able to be implemented in practice. Next slide, please. So on the conclusion end, scalable and sustainable approaches to equitable obesity prevention to be successful, we just cannot continue to only look at straight lines. That is as if everything is organized along causal chains of events. I think rather than that, we should think about a systems behavior that really emerges from its structure, of its feedback loops. And so So the idea here, as Peter Senge indicated, reality is made up of circles, but we see straight lines. That kind of is an idea that whose time has come. With that, I would say that in addition, the both and kind of thinking is probably more important than the either or kind of thinking. Meaning we need culturally centered as well as locally relevant solutions. We need individual and population-based solutions. And we need pragmatically responsive solutions, as well as theoretically evidence-informed solutions. And let me stop at that. Thank you.
Thank you so much, Nico. Hopefully they could put us all into a panel format here. And I'm going to start with some rapid fire questions for all of us. So this is actually for everybody, and maybe I'll prompt you to start. Yesterday we heard a lot about sort of systems thinking and system science. We started out with Russ Hammond and went on to many others, and all three of you alluded to system science in your work and your thinking. One of the biggest challenges I think that we all have been facing in this PSC world is engaging with multiple sectors, multiple communities, the multiplicities of doing this work. So what do you see, thinking forward to the next workshop, what do you see as sort of the top maybe 2 or 3 challenges with engaged multi-sectoral research and implementation science research in this space? And Stephenie, why don't I start with you?
Sure. So, in the work that I do, and Jamie, I know you also do work in the built environment, the sectors, the built environment isn't a sector in and of itself. There are multiple players and multiple actors. A lot of them are in government as the implementers, and then there are sort of the influencers, which are the advocacy groups and the community members, et cetera. They often don't speak the same language. They often, require level setting in terms of understanding and expectations on both sides. And then, of course, the timeframes often don't align with the research timeframe. So doing research becomes a little bit challenging. And so sort of, the community does this better than the researchers do in terms of getting people in the same place at the same time, in the same room. And so having those partners who understand the community and the advocacy groups who understand how decisions are made and how things work has been essential for us to try to get, a place at the table.
Super, thanks. Terry?
Thanks for that question. So a few things come to my mind. I guess one of the areas that I think we can delve into more in the next workshop is, really bring to light some new innovations that deal with the stickiness factor, in terms of interventions. So that means, there are people out there that are actually advancing this knowledge in terms of doing a better job at reaching certain segments of the population. Maybe they're not doing it in obesity or health even, but they're figuring things out, as well as actually keeping people engaged, right? So we need to kind of generate the demand for obesity-related interventions, policy or otherwise. We also need to be able to keep people engaged over a very long period of time. So that's one bucket. Just a quick example, our summer accelerator just launched this morning. This is our 5th edition, and one of the companies that got accepted into our cohort this year is called Breakthrough, and they specialize in engaging youth. And they're doing this, beginning to do this in the health sector, even though they started, from other sectors. But I'm gonna learn more about what their secret sauce is. But these are the kinds of things that we need to build, and incorporate into our work. The second bucket is, I think, what Nico kind of touched on, is really thinking about the integration of prevention and treatment. Right? We're not going to get ahead of the obesity epidemic if we're not doing both at the same time. And so what does that even look like, right? What is the optimal or translatable, transferable model where social care, clinical care, all the issues related to social determinants can actually be integrated into one whole? coherent approach. We talked about this over, many years now, but I think no one's really kind of quite figured out how to actually design and implement this. So that I think is an area that we need to, spend a little bit more time talking about. And I don't think core is very much about prevention, but this is still related, though I think we need to expand, the bucket a little bit.
Thanks. Nico, do you want to add here?
Yeah, so yeah, certainly, cross-sectoral efforts are needed, but who are the stakeholders that actually come to the table across those sectors? And my sense is that what is really needed is a focus on social capital. So trust, building social trust, rebuilding social trust, social cohesion, and social connectedness seem to me to be three areas of focus that are just in dire need to be addressed. We've seen trust really erode across so many different areas, whether that is government, whether it's healthcare, whether it's different industries. So how are we going to rebuild this so that these sectors can actually talk to each other with some level of trust to move towards solutions? And that's going to be hard work. My sense is that it will take really intentional and deliberate efforts to bring stakeholders together for that purpose. And it will need strong leadership from those sectors to step forward. So who are those individuals at the end of the day represent these sectors who are willing to talk? That seems to me to be a major culprit.
Super.
Can I add one more thing before we move on? Picking up on something that Terry said, I think that we need to be a little bit more mindful about talking about co-benefits and thinking about outcomes beyond obesity, physical activity, and nutrition. In the built environment realm, there are a lot of really wonderful co-benefits to community design interventions that influence physical activity, economic development, safety, all those things that people in the community and the decision makers care about more than they care about physical activity. And that's true in other realms as well. And so as we're designing our studies, I think we need to think about our messaging, how we frame them, and also about our outcomes. And then I think related to that, whenever I see the systems, slides that were shared, I'm always overwhelmed to think, how do we make a dent in obesity given this? And sometimes I think our standards for what we considered evidence-based are, when we do it based on obesity outcomes, a lot of times it doesn't work, but we see all these other really great outcomes. And so we need to be thinking about all of that as we build our new interventions, as we frame our old interventions, and as we measure our outcomes and think about what's successful.
And those outcomes may be the more appropriate targets on the time scale that we have, right? And changes in obesity might actually take longer. So.
Yeah, and that's exactly what the last panel was getting at, sort of broader social policies and their impacts on health outcomes, which ultimately could affect obesity and related outcomes. So I think there's a consensus in today's sessions about this point. So thank you. I'm going to try and consolidate some of the questions that come in the chat into a broader question. So Nico sort of alluded to, essentially the political determinants. Let's talk about these other determinants of health, the political, the commercial determinants. One of the questions that came in is, can whole of systems approaches to obesity prevention work without, for example, dramatic increases in regulation of commercial actors or addressing industry behaviors? That's the first part of the question, then I'll follow up with the second part. So anybody want to take that one? It's really food oriented, I think, more than anything, but want me to repeat it, Terry?
Well, so I think certainly they can work, but probably, in my view, more importantly than anything is to make sure that we bring all those actors to the table and figure out a way to co-create an approach. It seems to me that once you have people at the table and you can actually address these issues, there are going to be benefits that can be extended to all actors. And making decisions in a vacuum or in a silo away from those actors just makes everything more difficult once you implement. So So yeah, I think a whole of system approach can work, but we need to be very intentional about including everybody.
And that was
Yeah.
one of the promises behind the roundtable, right? On obesity solutions
Yeah,
is getting all the actors at the table. So
Yeah, I agree with that. I would just also add that, while I believe that there's a very important role for regulatory approaches, it is also important that we are aware that any time that there is an action, be it regulatory or otherwise, there's going to be a reaction, right? Regulations do not exist and they don't get implemented, in silos. They're connected to other systems. In society. And so we have to be mindful of, potential unintended consequences. And I think that one area where regulations can be really powerful is actually in creating a different but even playing field for commercial actors, right? And so if whatever regulation it is that we're setting ends up creating, an even playing field so that all commercial actors have to compete in a different way, but starting from the same baseline, that can be very powerful. But if you have regulations that affect some that maybe give a advantage to some commercial actors, but a disadvantage to others, then we have a problem.
great. And then the corollary here, Nico, you alluded to the political factors and how they can be addressed or influence, PSC implementation. Can we talk about this a little bit? Because, the next methods workshop will focus on methods. And I think the reality of the political environment and the political feasibility really sort of has an overarching effect on the likelihood of PSC strategies being implemented in practice. So Stephenie, I see you shaking your head and I know you've had some experience with this. So do you want to start off?
No, I think that that's a great question, and it's a really hard one to answer because we've seen pretty major ups and downs, and what the differences in the political climate in this space look like over the last 7 years, and so we kind of know what the next 4 years might look like. But I think that the reality is that we need to find ways to work with, within the context as best we can. And that requires understanding how decisions get made, what the touch points are, what the leverage points are, and to think really, really carefully about how we introduce our ideas in a way that can be adjusted so that it's palatable to people who may not be on the same page from a political spectrum perspective.
Super. And I'm just going to take prerogative here. We have one last question in the chat and we have 2 minutes and 45 seconds. So I'm going to get to this one. How can those who are doing this PSC work in practice best collaborate with research partners to elevate the science? We're building the plane as we're flying it. Is there a better way to capture outcomes? I read that question, so I can't interpret it, unfortunately.
Well, I can't say. I'll plug, Jamie, our own network. If you're somebody who's interested in the built environment and physical activity, or if you're interested in food policy, CDC runs 2 research to practice networks, PAPRIN and NOPRIN. Jamie and I have the privilege of leading NOPRIN, and Dr. Blank is the CDC liaison.